this? Okay, let us continue with chapter 28, drugs for diabetes. So last week, diba, we learned the signs and symptoms of diabetes, the types of diabetes, wherein the most common is syempre type 2, the non-insulin dependent diabetes mellitus. And then also we are done discussing the different types of insulin preparations in the market. They are prepared through DNA recombinant technology, wherein they have this DNA of the human insulin, inject it to microorganisms like the yeast and the E. coli, which are strains na not really causing diseases. And then as these microorganisms multiply, syempre the DNA for the human insulin will also multiply. They will extract it, process it to become insulin, and yun na yung mga available insulin preparations natin sa market. Now, we ended here with the insulin delivery systems. They can be dispensed through a portable pen injectors. We just have to change the needle for every injection. And then we also have continuous subcutaneous insulin infusion devices, or we call it CSII, or the insulin pumps. Now we have different types of insulin, diba? The rapid acting insulins, where we can give them before meals to prevent the postprandial excursion of insulin. Insulins like Apidra and Glulicin, those are our rapid acting. And then we also have our short acting, which can also be given before meals to again prevent the increase of insulin after eating. And then we also have intermediate acting insulin, our NPH insulins. The short acting are our regular insulins that can be given through IV administration, which is actually a board exam question. And then again, the intermediate insulin, we have the NPH insulin, and we have premixed insulins also. And then lastly, we have our long-acting insulin. Most of them are given once a day. Our Deglodec, our Lantus, ayan, mga long-acting insulin natin yan sila, to help regulate the blood sugar level for a person, especially those that are insulin dependent. But actually, we can also give insulin to type 2 diabetes mellitus. Now, for the insulin regimens, we have here the so-called intensive insulin therapy. Like for the case of the type 1 diabetic patient, insulin talaga, intensive insulin therapy sila. And how is their dose computed? We have here total daily insulin requirements in units. We just compute it using their weight in pounds and then divide it by 4. Yun yung ating, wait lang, na-distract ko sa sige chat. Yun yung ating unit dose for our insulin. So for example, pila ka pounds mo karon? Example, 100 pounds na tao divided by 4, that will be 25 units of insulin yung kailangan i-inject sa kanya in a day. So yung pen, example, pen injectors natin, sa dulo nun, meron yun for adjustment of the units or the unit dose. So kung 25, for example, kung once a day lang, the whole 25 units will be injected directly to the patient. Kaya lang, medyo mahal, no? I cannot remember how many units yung isang pen. Meron kasing mga pen na 100 units lang. So if in a day, kailangan yan ng 25 units, so upat ka adlaw lang pud to ang isa ka pen, and ang isa ka pen tagpila na siya. Medyo expensive ang insulin therapy. Now aside from that, aside from giving insulin, syempre the meal or snack and high blood sugar correction boluses are also included in the prescribed formula. Meaning diet is also included here if the patient undergoes intensive insulin therapy. Now, we also have conventional insulin therapy. Ito naman is prescribed for people with type 2 diabetes mellitus who are felt not to benefit from intensive glucose control. For example, they are given oral hypoglycemic agents like Metformin, but then for the long term of treatment, walang pagbabago sa kanilang blood sugar level, mataas pa rin, yung prescribing physician will add insulin in the therapy. We call it conventional insulin therapy. My father actually was given insulin dati. So dalawang klase, the short-acting and the long-acting. Pero type 2 diabetes yung sa kanya. So kasi pagka-diagnose, umabot ng 300 plus yung kanyang blood sugar level. So hindi kasi siya kakayanin din ng mga oral hypoglycemic agents na mapababa agad. So nag-insulin. Okay? Now, insulin treatment of special circumstance, we have diabetes ketoacidosis. I have mentioned this. This is one of the life-threatening complication of type 1 DM, though sometimes we see it sa people with type 2 diabetes mellitus. And this happens when there is inadequate or insufficient insulin level in the body. Consider gainom pa rin sila ng oral hypoglycemic. Yeah, others will still be prescribed with the oral hypoglycemic agents in combination with insulin. But for others like my father, I think wala siyang oral. Purely insulin lang talaga siya. Even though type 2 diabetes mellitus yung sa kanya. So it is actually dependent on the case of the patient. If ano yung problem sa kanya, kung i-add lang ba si insulin para doon sa mga oral hypoglycemic agents. So depende, case-to-case basis, pero yes, we can do the combination. So going back, the diabetes ketoacidosis is due to the insufficient insulin in the body, or maybe there is an absence of insulin in the body and that walang replacement. So na-mention na ko na ito last week na the body will be looking for other source of energy since the glucose cannot enter the cell kasi walang insulin. So it will be on the fats. There will be breakdown of fats. Thus, there will be release of a lot of free fatty acids, and that these free fatty acids will be converted into ketones. However, these ketone bodies are toxic in the body, so the patient may experience diabetes ketoacidosis, wherein the pH of the blood will really decrease. And then meron na yan siyang mga sequelae, mga medical sequelae after pag mag-acidosis na ang blood. So this is life-threatening. Signs and symptoms of ketoacidosis, these are normal, nausea and vomiting, abdominal pain, and then the Cosmos respiration or the deep, slow breathing. Kanang murag ginahangak nga ano jud kay deep jud kaayo ang ilahang breathing. We call it Cosmos respiration. And then there will be change in mental status due to the change in pH also, and the elevated ketones and glucose both in the blood and the urine. And this is where acidosis is. Arterial blood pH higher than 7.3. Actually, that is not supposedly. No, the blood pH will be 7.3 and higher, but the what do you call that? Respiratory na pH is mababa. So there will be low bicarbonate. Baliktad pala, the blood will be, pwede siyang magtaas sa 7.3, pero sa respiration na part, there will be low bicarbonate and magbaba ang pH. Okay? So, and then we have the hyperosmolar hyperglycemic syndrome. This one naman is commonly seen as complication for type 2 diabetes, the diabetes mellitus, wherein the patient will also have high and as in increased blood glucose level, and that will lead to dehydration. Because remember, glucose has osmotic na property kung asa ang glucose mosunod si water. And thus, if we have a lot of glucose in the blood, mosunod dito si water, cells will be dehydrated. And then aside from that, if glucose is found in the urine, so mosunod po si water dito, you will have more, higher volume of the urine, and that will add to the dehydration of the patient. So since dehydrated ang patient, the patient will may experience being in a comatose state. So what's the problem here? Dehydration. So kung wala na gani, taas na gani kay sugar niya, na dehydrate pag yun due to other cases, musamot ang hyperosmolar hyperglycemic syndrome sa atuang patient. So for example, nagdiarrhea ang atong patient niya, taas pa jud kaayo iyang blood glucose level, grabe na gyud to siya nga dehydration. Or naapay ginagamit na other medications. So for example, atong patient is having polypharmacy, naa siya'y drugs for diabetes, kaya na siya diabetes, tapos naapod siya sakit sa heart, then pwede siya tagaan o papaihi, diuretics. So musamot pag yun to ka-add up into the dehydration. So magkaroon og problem with the mental state of the patient. So these two are the complications of diabetes mellitus, and kapag may ganito ang patient class, we can actually give insulin. Kasi the problem here is the increased blood glucose level. The complications of insulin therapy. Okay, sige, moving na. We have sympathetic complications of insulin kasi pwedeng magkaroon ng hypoglycemia ang patient, especially if hindi tama yung pagka-compute ng dose ng insulin, na sobraan ng ato ang patient. At risk po siya of having hypoglycemia. Now, what are the signs and symptoms of hypoglycemia? We have here sympathetic signs and symptoms. The patient may experience palpitations or tachycardia. So there will be fast heart rate, and then you will see a patient na nag-hypoglyclas kay, there will be sweating, grabe nga sweating, and then there will be tremors. And then there will also be parasympathetic na signs and symptoms for hypoglycemia. We have nausea and hunger. And for some, na grabe na gyud kababa class ang blood glucose level, the patient may experience convulsion, and then some will experience being in a state of coma. So mao ni siya. That's how you know that you are experiencing hypoglycemia. Ang mga patients natin na diabetic, since they have high sugar level, di ba, ginahatagan nato silang insulin, and then others will also be given oral hypoglycemic agents. Actually, we will also monitor them kasi basig masubraan sila, mas delikado ang hypo kaysa sa hyper. Ang hyper is like killing me softly, slowly also. Pero ang hypo is diretso kasi siya, pag mubagsak na imuhang sugar, makomatose din na ang patient. Okay. Ngano mag-convulsion if hypoglycemic? So remember that our neuron, also the food for our neurons to keep them functional is still glucose. So just like the other types of cells in the body. Now, since there is hypoglycemia, there is decrease in the source of energy in the body, there will be abnormal firing also. There will be abnormal functions of these neurons leading to the convulsion. So that will be the reason. Okay? So, ang uban, makumatos diretso. So, muna ang uban class, either naga-insulin or oral hypoglycemic agents, pag napansin nila ilahang sarili na they are experiencing these signs and symptoms, they will actually know na naga-hypoglycemia na sila. So some will like eat candy or mag-inom og coke ang uban mukaon just to increase their blood sugar level. Same ang reason, ma'am, kanang mangurog kung gutom, nag-abnormal. Not really kanang abnormal firing ha pag nagagutom ka niya gikurog na ka. This is more of the sympathetic signs and symptoms of hypoglycemia. So hindi siya really on the convulsion na part kasi ang convulsion is on the brain. There is problem of the neurons na naga-fire sa brain nato, so naga-convulsion siya. Pero sa kanang gigutom ka, grabe na gyud imong kagutom niya, nagkurog na kapag kaumag. That is more of a sympathetic na sign and a symptom for hypoglycemia. Tremulousness or there is tremor. So naga-hypogly pug ka na ha if nagkurog na ka sa kagutom. Grabe. Grabe na gyud. So remember, we have here hunger and then you have tremor. You will have hypoglycemia. Okay? Grabe yun din yung paggutom kay nagkurog na yun. So again ha, hindi basta-basta ang insulin therapy. Hindi pwede nga, taas kaya ang sugar, bumbahan na ito siyang insulin. No, we don't do that. Kaya delikado ito ang patient for hypoglycemia. Lisod kaayo, there will be comatose. Okay? Questions? Questions? Wala? Kailangan i-compute ha, kailangan i-compute ang insulin na dose. And then we have immunopathology of insulin therapy. There are people who are actually allergic to insulin. So this is an immediate type of hypersensitivity, though this one is a rare condition, but the patient may experience urticaria due to the release of histamine kasi nagkaroon ng antibodies against the insulin. So that will be our problem now if the patient will experience this one, allergic reactions to insulin. So we can help the patient through administering antihistamines also kung kailangan yun niya mag-insulin therapy. But if type 2 diabetes mellitus naman, then we can just shift to the oral hypoglycemic agents. And then another problem here is the so-called immune insulin resistance. The other one is just allergy ha. Ito naman resistance. So this happens when the patient develops also antibodies that will neutralize the action of insulin. Ang kani, antibodies that will cause the release of histamine, thus the allergic reaction. This naman, antibodies will be formed when you give the patient the insulin preparation from the market, but these antibodies will act on the insulin itself, neutralizing the effect of insulin. So that's the problem if the patient develops a resistance. Okay? And then another one, which is a board exam question, lipodystrophy at injection sites. There will be atrophy class of the subcutaneous fatty tissue sa injection site. So dili na siya pag, ang inyong tandaan, if you are injecting insulin to a patient, hindi dapat the same area. Again, hindi dapat the same area sa, example, 4 times a day siya mag-insulin. Sa 4 times a day, dire lang yun sa tiyan. Isa ka part lang pag yun sa tiyan, imuhang gina-inject. No, kasi that will lead to the death of the fatty tissues there kung asa nimo siya gi-inject, and mabalaan na nimo na there is death kay mo itom naman na siya. So all the medical health practitioners, the nurses, the pharmacists, the doctors know this, na if you're administering insulin, kailangan balhin-balhin na siya. Okay? Different areas of the body. So if you are done with sa right side sa stomach, sa udto, diri na po ka sa left side, sa gabi, sa kamot na sa, just look for body parts na rich in adipose tissues. And then, ilipat-lipat natin yung pag-inject. Okay? Questions so far before tayo mag-move on with the oral anti-diabetic agents? Wala? Wala'y pangutan na sa insulin. Sa gani ang insulin nga pwede ihatag intravenously. What was that again? The insulin that can be given. Kasi the insulins are administered subcutaneously. So what was that? Insulin na pwedeng ibigay intravenously.
Regular.
Okay, very good, Sarah. It's regular insulin. How about the peakless insulin? Kasi remember, in your biopharm, you have the AUC, area under curve, but there is an insulin na walang peak. Mag-plateau lang siya. What's the name of the insulin again? Insulin. Ito mula ito nilang answer. Before oral antidiabetic agents. What was the insulin na peakless? Okay, very good. The glargine, insulin glargine. And do not forget the insulin glargine is a long-acting insulin. So most of the time, these long-acting insulins are given once a day. But for rapid-acting and short-acting, it can be actually given 3 times a day or more. Example, kapila mo kaon ng ato ang patient, kana ihatag i-inject ang insulin. Pero ang problem again, it can cause atrophy of the subcutaneous tissue. So kailangan natin siya i-change ang area where we inject the insulin. So those are the things. The intermediate acting can be pre-mixed, mix of short acting and intermediate acting. The reason is to have a rapid onset pero longer duration of action. So that's the reason why we premix our insulin. So we are done with our insulin. Let's go now sa ating oral antidiabetic agent. So please listen kasi these are very common drugs in the market. Aside sa ating mga drugs for the cardiovascular system, mga antihypertensive drugs natin, ito yung isa din sa parating yung mai-encounter when you work in community or even in the hospital. So we have a lot of categories for our oral antidiabetic agents, though may nasali lang dyan na amylin analogs which are administered subcutaneously. Pero hindi kasi natin siya masali doon sa insulin kasi this is not an insulin. However, we have the categories, the insulin secretagogues, from the name itself, secretagogues, meaning they will trigger the secretion of more insulin from the pancreas. We have 3 types of drugs here, the sulfonylureas, meglitinides, and the diphenylalanine derivatives. And then aside from our insulin secretagogues, we have the biguanides, the thiazolidinediones, the alpha-glucosidase inhibitors, the incretin-based therapies, and again, the amylin analogs that are administered subcutaneously. So again, insulin secretagogues, from the name itself, they will trigger or increase the secretion of insulin from the beta cells of our pancreas. So this one is given for type 2 diabetes mellitus. We cannot give this for type 1 kasi di ba once sa type 1, sira na talaga ang mga beta cells sa pancreas. So the patient can no longer produce his or her own insulin. So kani secretagogues, paano pa to nimo ma-trigger ang pancreas og secrete kung naguba na siya. So type 2 gid siya. Insulin secretagogues are given to type 2 diabetic patients. And then we have the biguanides, we only have one biguanide actually, the Metformin. Under yan siya sa biguanides. Ang trabaho naman ni Metformin is to decrease hepatic glucose production. Remember, we have stored glycogen in the liver, and if there is glycogen, anong trabaho ni glycogen? It will get the stored glycogen from, we have the insulin, and what's the other one? Nakalimot na hinuon ko. What's the other one? Let's go back. So, yung glycogen, no? Glycogen. It's the glucagon. Ano mo sila parihas? Yung pangalan ko. Kalimutan ka. Balik. Okay. We have here the biguanides. Remember, we have the stored glycogen in the liver, and in the presence of glucagon, the glucagon will get this stored glycogen, break it down into glucose, and the glucose will be transferred back or transported back to the blood. So that's how we do the hepatic glucose production, and that will be inhibited by the biguanides. Okay. And then we have the thiazolidinediones. agents which reduce insulin resistance. Remember sa type 2 diabetes mellitus, either the patient is resistant to the action of insulin, merong enough insulin class in the body pero the cells are resistant. So ito yung binibigay natin, thiazolidinediones, or the patient is producing insulin pero dili enough. So pwede na to ihatag si secretagogues to trigger the pancreas to release more insulin. And then our incretin-based therapies, they control post-meal glucose excursions by decreasing insulin resistance and decreasing glucagon secretion. So this one is for after meals na glucose control, wherein the action is both on the decrease of the resistance in insulin and at the same time, i-decrease natin yung glucagon. Kaya ang trabaho yun ni glucagon, get the glycogen in the liver, break it down to glucose and transport the glucose back to the blood. And then that's the same thing with the amylin analog. This decrease post-meal glucose levels also, and at the same time reduce appetite. And lastly, we have the alpha-glucosidase inhibitors. This one naman is for the digestion of the carbohydrates. So they will slow down the digestion of the carbohydrates so that they will not really be metabolized into glucose. That's how the alpha-glucosidase inhibitors work. Magkaunta og carbs, and most of the carbs that we eat are polysaccharides. And inside the body, diba, they will be degraded into disaccharides or monosaccharides. And yung glucose natin is a monosaccharide para hindi siya maging glucose. I-diretso na lang natin siya excrete. Busog tayo pero there is no increase in the blood sugar level kasi wala na digest. Trabaho yun ni alpha-glucosidase inhibitor. So let's discuss them one by one. Any questions first? Any question first before tayo mag isa-isa ng ating mga anti-diabetic agents? Sige. So let's start with our insulin secretagogues. The first one here is the sulfonylureas. So syempre the mechanism of action, since insulin secretagogue siya, these drugs will trigger the pancreas. So si pancreas ang target nila. This will target the cells in the pancreas to release more insulin. But at the same time, they have the additional work of reducing the amount of glucagon in the blood para walay magsigig produce og glucose from the liver. Now, these sulfonylureas are divided into two, the first generation and the second generation sulfonylureas. Sa name pa lang, mabalanahan na naani siya sulfur content. Thus, we don't give sulfonylureas to G6PD patients. Okay? Now, we have the first drug here under the first generation sulfonylurea. We have the Butamide, and then we have also the chlorpropamide, but both of them are not really commonly seen in the community. Okay? They are not really that highly prescribed, the first gen. So the Butamide has a short half-life, and actually, short ang kanyang half-life, pero it is considered the safest na sulfonylurea for our elderlies na diabetic. What's our problem with Butamide? It will have prolonged hypoglycemia. It will really cause a lot of insulin to be produced in the body and thus leading to the decrease of the blood glucose level, and that the patient will really experience hypoglycemia here. Now remember, na-mention ko kanina, delikado si hypoglycemia. Though among them, Butamide is the safest sa elderly patients natin na hindi sila mag-experience ng hypoglycemia. And then we have the chlorpropamide, which is maintained at 250 milligrams and most of the time given in the morning. But unlike tolbutamide na hypoglycemia lang yung parang problem talaga, chlorpropamide has a lot of side effects. We have the jaundice. If it is given at 500 milligrams, it will target the liver and then also the kidneys. And there will be hyperemic flush after alcohol ingestion in genetically predisposed patients. So you don't give also chlorpropamide in concomitant with alcohol. Especially if the patient is sensitive to it, there will be flushing. And then delusional hyponatremia and other hematologic toxicity. So this is one of the these are the reasons why we don't really see chlorpropamide that much in the community. And then another member of the first generation sulfonylureas is the Polazamide, which is actually comparable to chlorpropamide in terms of its potency, but it has a shorter duration of action. So itong tatlo na ito, first gen sulfonylureas, and ulitin ko, when you work in a community pharmacy or even in the hospital, you will not really see this drugs that much na piniprescribe. Okay? Ang parati nating makikita in the community though for the sulfonylureas to increase the insulin secretion are the second generation. We have the Glyburide, though you still have there the hypoglycemia and the flushing after alcohol ingestion. Ano itong problem? Our diabetic patients, some of them are alcoholics. So, either there will be enzyme induction or enzyme inhibition depending on their case sa pagiging alcoholic. And at the same time, they might experience adverse drug reactions when they ingest alcohol sabay with our drugs. So especially our Glyburide and the other drugs for diabetes, magkaroon sila ng mga adverse drug reactions. And then Glyburide is contraindicated for those patients na may problem na with the liver and the kidneys kasi maka-injury sila sa mga organs na. I mean the Glyburide. And then the Glimepiride has the shortest half-life among our second gen sulfonylureas, and since it has the shortest half-life, it will be given 30 minutes before breakfast para after eating mag-take na din siya ng kanyang action. But just like the Glyburide, this is also contraindicated for those patients with problems in the liver and the kidneys. And then we have the Glimepiride, which is given once a day as monotherapy. Monotherapy ha siya lang. The Glimepiride, yan lang yung ibibigay sa patient natin, or pwede din naman siyang i-combine with the insulin. So other types of second generation sulfonylurea na hindi na mention dito is si glibenclamide. Again, si glibenclamide is also under here in the second generation sulfonylureas. So hindi natin maisa ang kanilang dosage. Some of them are given once a day. Others will be given twice a day or more than that if it has a short half-life. Questions about our sulfonylureas? Wala, pakidugang si glibenclamide ha, kasi I was not able to include glibenclamide here. And my slide class is, wala, hindi ko din in-include ang mga brand names. So it will be your task now to look for the most common brand names for these drugs. Okay. So let's move on. Oops. With the second group of these are still insulin secretagogues pa rin ito, pero hindi na ito kasali sa sulfonylureas. This is another drug, another group of drug repaglinide lang yung nandito. Now, this is again as insulin secretagogue, and just like the sulfonylureas, this will trigger also the pancreas to release more insulin. And actually, most of them is, their action is on the inhibition of potassium na work sa pancreas. When you inhibit that, it will actually increase the exocytosis of this insulin from the beta cells of the pancreas. Now, the first member of this group is the repaglinide, which has a rapid onset of action, and thus this is used, this is given before meal to prevent increase of insulin after eating. We call that postprandial glucose excursion. And the advantage of using repaglinide compared sa sulfonylureas, wala itong sulfur in its structure, thus wala tayong mga skin conditions na pwede ma-experience. Mga skin conditions like, ang pinakamalala is the SJS, the Steven-Johnson syndrome. Yun naman talaga ang mostly effect of sulfur sa skin, the SJS. Some will just be allergic, but if grabe na talaga, SJS na yun siya. Now, that is the advantage of repaglinide over the sulfonylureas. And then, we also have another group of drug here na insulin secretagogue pa rin. We have the diphenylalanine derivative. Just like the sulfonylureas, this will also trigger the release of insulin from the beta cells of our pancreas through the inhibition of potassium gihapon. So, i-close niya ang ATP-sensitive potassium channels to increase the exocytosis of the insulin. So we have here one drug also, the nateglinide, which is also given before meals. And since I have mentioned that most of our secretagogues are contraindicated to patients with kidney problems, itong nateglinide is considered the safest for the patient with reduced renal functions. And nateglinide can also be given na monotherapy, siya lang isa, or pwede din in combination with other drugs, especially non-secretagogues like metformin. Metformin is not a secretagogue, that's a big one. It has another mechanism of action. So mas effective si nateglinide kung i-combine siya with non-secretagogues. Now, when do we use nateglinide? This is also for the postprandial blood glucose excursion. So most likely we give this before meals. Yun yung problem with our patient kasi they will experience as in hyperglycemia after eating. Okay, questions about our insulin secretagogues before tayo mag-move on with our biguanides. Balik? Sure na?
Ma'am, may question po, ma'am.
Yes.
Ma'am, di ba ang uban mong good na physician, ma'am, kay pagkataas kaayo ang sugar good sa patient, ma'am, kay ginahatagan nila lagi ukoan, ma'am. Dalawa ka anti-hyperglycemic.
That is what they do, especially sa type 2 diabetes mellitus. They don't really kasi test how much insulin is being produced, so we don't know whether the problem is on the resistance or in the secretion. Di ba man natong problem with the type 2, either sa secretion kulang or enough ang insulin secretion pero na ay resistance. So what they do is naga-double treatment sila. Either they give the secretagogue and they partner it with a drug for the resistance or other types of drugs just to target kung unsa man ang problem in the body. So wala na sila by the way, please take note, the doctors don't really give, that is actually a rule. We don't do duplication. So hindi sila bibigay ng pareho ang mechanism of action. Kaya ang tawag na to ana duplication. So kung naga-partner na sila, naga-combination drug na sila, the combination will be different na mechanism of action. So that is to aid kung kani isa ka drug sa secretion, so para mag-secrete og daghang insulin, tas i-partner siya for example with biguanide, and sa biguanide naman para sa hepatic production of the glucose. So lahi-lahi sila, pero at the end, it will help the patient, especially if taas na kayo ilahang blood glucose level. So nagit tayo patient, ana, they don't really experience signs and symptoms, but kung i-test na to ang ilahang blood sugar, mag-error ang glucometer sa kataas. Nagyoy nga na mo error, basta dili na kaya sa glucometer ang kataas ilang blood sugar level, mag-error na siya. Pero wala sila ginabati, ana. Ang uban na, ang uban wala. Pero ang taas magud nga blood glucose level will not really kill you agad-agad. Ano lang na siya, complications ang sunod before mamatay ang patient due to the diabetes. Unlike the hypoglycemia, napatay dyan kapag mag-hypoglycemia ka, makumatos man ka, ang hyperglycemic. So, ano na sila, nagka-partner, nagka-combination ang doktor kung taas na kaayo. Dili na siya kaya sa isa ka mechanism of action lang na ang reason. Okay? And then we have the biguanides. We only have one drug here, the metformin. And what is the action of metformin? This one reduces hepatic glucose production through activation of the enzyme AMP, or the adenosine monophosphate activated protein kinase. So series of biomolecular pathways kasi ito in the body, and that but this one involves the action of glucagon getting the glycogen stores in the liver, i-break down siya, and then produce si glucose, transport it back to the blood, and that's it. Mutaas ang blood sugar level. Pero in the case of metformin, let's inhibit the pathway so that there will be no additional sugar na mabubuo galing sa ating liver. Okay, that's metformin. But this one is a board exam question. This is actually the first line drug for type 2 diabetes mellitus. Ito yung pinakaunang binibigay ng doctor, ng physician sa mga newly diagnosed patients. First line C, metformin. Okay, now if you administer metformin, the patient may experience less fasting hyperglycemia and lower postprandial hyperglycemia. So we call the effect euglycemia. As si metformin kasi can actually decrease the blood sugar level up to the normal level. Kaya dyan niya ibagsak imuhang blood glucose na mo patong siya sa normal level. Pero metformin is also notorious of causing hypoglycemia. So ang uban pod masubraan og metformin, mag-hypoglycemia na sad. Okay, again, the patient may experience less fasting hyperglycemia. Ang mga patients, by the way, di ba ang mga diabetic patients na to, dili sila pwede magutman, dili sila pwede mag-skip og meals. Nga naman, musamot og kataas ilahang blood sugar level. Wala sila ni kaon ha, nag-fasting sila, pero musamot og kataas ilahang blood sugar level. Why? Remember, our liver is capable of producing the glucose from the glycogen store. So since we are giving metformin, then that's the reason why there is less fasting hyperglycemia and lower, syempre, lower postprandial hyperglycemia after eating. So muna siya ang advantage ni metformin, and that is the reason why this one is given as the first line drug. Again, first line therapy for type 2 diabetes. And this is an insulin sparing agent and does not increase weight or provoke, does not really provoke hyperglycemia most of the time. Kay taman siya sa normal level, masubraan lang ka, that's the time mag-hypoglycemia ang atuang patient. But another advantage is kung kaniyang ihatag manggod, wala jud siya, dili kayo necessary na maghatag og insulin pa sa atuang patient. And this does not increase weight kasi most of the time di ba ang patient na diabetic mo payat og kalit. Pag na-treat na ang ilahang sugar or na control ang ilahang sugar, ang uban natin ng mga diabetic agents, anti-diabetic agents can actually cause weight gain. But that's one thing about metformin, it does not increase weight. Actually, it can decrease weight. It can decrease weight. So, meron tayo class mga obese patients, since we don't really have drugs for obesity nowadays. Meron, pero yung iba, we cannot tolerate the adverse drug reactions. And yung iba is analog of the methamphetamine. So, dili kaayo pud sila gina-prescribe. Ang uban doctors, if naa sila obese na patient, ang ginahatag class metformin, pang papayat. Okay? Again, it can decrease weight because of the decrease in the sugar release. Okay? Take note of that. That's a board exam question na makapayat si metformin, thus pwede siya gamiton for obesity. But I'm not telling you na if you are obese now, mag-inom og metformin ha. This has to be prescribed by the physician kasi the physician should assess your condition first before taking metformin. Now, toxicities of our metformin, we have here the GI distress, we have here anorexia, nausea, and vomiting. Normal yun na siya sa mga drugs. Abdominal discomfort and diarrhea, but for the board exam question, it will be the lactic acidosis. Kasi sa pathway in the inhibition of hepatic glucose production, kasali doon ma-impair ang lactic acid metabolism. So lactic acid will be accumulated in the body, and since it is acidic, it will really cause acidosis for the patient. So this is naman is the life-threatening na adverse or na toxicity of our metformin. So that is the reason why if you are obese now, please do not take metformin kasi you have to be assessed first, and that kailangan natin maiwasan ang lactic acidosis. The pH of the body, pag baba na sa 7.35, acidosis ang tawag, and that will impair the functions of our organs and tissues. Okay? Contraindications ng ating metformin, renal disease. We don't give metformin for patients with problems in the kidneys. And another one, alcoholism. That is our number one problem in the community. Diabetic patient taking metformin but alcoholic. So what happened to the drug? Wala effect si drug. It can also cause lactic acidosis. At risk ang patient natin for toxicities. At risk siya of having complications sa kanyang diabetes kasi wala nang effect yung drug. And then at the same time, metformin is not good for those with problems sa liver. And conditions predisposing to tissue anoxia like chronic cardiopulmonary dysfunction. Due to the impairment in the metabolism ng mga processes, we don't give metformin for those na posibleng makaka-experience ng anoxia, kulang ang oxygen sa mga tissues. Again, like chronic cardiopulmonary dysfunction. Questions about metformin before we'll move on to thiazolidinediones. I still have time. Let's admit. After na to mag-antidiabetic, I think I'll be discussing anti-cancer agents. So please prepare yourselves. That will be a series of complicated topics pag anti-cancer agent na ta. Absorbing pa? Sige. Yeah, I don't expect you to absorb everything sa kadaghan. Excuse me. So we have here thiazolidinediones. Again, the group of drug is thiazolidinediones. Ikatatlo na niha, insulin secretagogues, biguanides, and then thiazolidinediones. What's their mechanism of action? They act to decrease insulin resistance. Again, it's the insulin resistance ang dinidecrease. So, most likely given pa rin for type 2 diabetes mellitus. So, they are actually ligands of this receptor, the PPAR gamma. or the peroxisome proliferator activated receptor gamma. That's the meaning ha, PPAR gamma, peroxisome proliferator activated receptor gamma. Ligand sila for this. So, dito sila mag-bind sa PPAR gamma. Now, what is the action of this receptor? It modulates the expression of genes involved in both lipid and glucose metabolism. Again, ang trabaho kasi nitong receptor na ito is more on the lipid and glucose metabolism, and that taking this will decrease the insulin resistance para ang mga cells maging sensitive na ulit kay insulin. Okay? Side effect, fluid retention, increased risk of heart failure. Remember, appeal si lipid din ha. Increased bone fractures in women kasi this will affect the bone metabolism also, labi na sa mga babae. So mag-brittle ang bones ani. Wala nang problem with the thiazolidinediones. Decreased triglyceride level and increased HDL and LDL level. That is why we have here risk of heart failure. The fats and the oils will be decreased, but the cholesterol level will be increased. Hepatotoxicity, and unlike biguanides, this can cause weight gain. And this is also contraindicated in pregnancy because again, one reason for that is may problem tayo sa bones nito, and then infant sa sulod is developing. So, dili jud siya pwede ihatag sa pregnant women. Now, one example of a thiazolidinedione is the Pioglitazone, which has an activity both on the PPAR gamma and the PPAR alpha receptors. Okay? PPAR alpha and PPAR gamma. Which are both the same receptors, pero both used in the glucose and the lipid metabolism. However, when you are taking pioglitazone, this should not be taken concomitantly with estrogen-containing contraceptives. Nga naman, this will actually cancel the effect. This will be an antagonist sa estrogen na contraceptive, and thus mabuntis ang patient. So mao gani naga-take og estrogen containing contraceptive, di ba, para dili mabuntis, but since this is an antagonist to that, wala, mabuntis yun ang patient. And then we have the rosiglitazone, which is ang problem naman is more on the development of a cardiovascular condition. So, paano natin malaman yung pangalan ni thiazolidinediones? Mag-end na sila sa glitazone. Pioglitazone, rosiglitazone. I'm not familiar with the other ones though. But pag may makita kayo na drug na glitazone ang ending, that's a thiazolidinediones. That's an insulin resistant decreasing na drug. Okay? Para maging sensitive na ulit ang cells natin. Their action, take note, it's on the PPAR receptor. Now, we have here the alpha glucosidase inhibitors. What is their mechanism of action? Competitive inhibitor of the intestinal alpha glucosidase and reduce post-meal glucose excursions by delaying the digestion and at the same time absorption of starch. I actually have a diagram for this. Pero let me draw na lang. So, di ba, countag carbs. Ay, hindi ko ganahan sa color sa pen. Kadyo. So, countag carbs. Mostly sa itong ginakaon na carbs class are what they call that, polysaccharides. Okay, in your biochem, where does carbohydrate digestion start? Asa nag-start ang carbohydrate digestion? Si Ma'am Cherry yung teacher ani. Asa napit nag-start? Okay, very good, Sarah. Sa mouth. Like, sa mouth. Asa na, unsay na sa mouth?
Saliva.
Kasi nasa saliva.
Salivary amylase.
Thiolate.
Very good, very good. That's amylase or the thiolate. So sa mouth, we have here the amylase, the salivary amylase, or we call it thiolin. Okay? Tapos, syempre, ma-degrade na siya. Pwede siya mahimo og oligosaccharides. Sa mouth, ha? Tapos, how about the other type of amylase? Pancreatic amylase, right? So sa pancreas, we have another type of amylase here that will further degrade this one. Pwede into disaccharides or pwede na po monosaccharides. Pero kung disaccharides pa na siya, in our intestine, we have the so-called alpha-glucosidase. Actually, that's one of an amylase that will further degrade this disaccharides to monosaccharides, especially glucose. So, ingana ang pathway na to ha sa pag-digest. I'm talking about digestion of the carbohydrates from dietary origin. Polysaccharide going into oligosaccharides through the salivary amylase. And then we have the pancreatic amylase that will further degrade the oligosaccharides to disaccharides. And then in the intestine, we have another enzyme, the alpha-glucosidase, to be specific. The disaccharides will be converted into glucose. And this glucose from the intestine will be transported into the blood. Okay? Para mag-glycolysis siya to give us energy. If we have too much glucose, it will be undergoing glycogenesis to be stored in the liver. And if may problem tayo sa insulin, mudaghan ang blood glucose levels. Based sa ato ang mga ginakaon, kung carbohydrate-rich foods ang gina-take nato. Now, for the alpha-glucosidase inhibitor, syempre this will inhibit this one. This part of the pathway. The alpha-glucosidase inhibitors will inhibit the alpha-glucosidase enzymes so that the disaccharides will not be really converted into glucose. It might delay the digestion or it might delay the absorption because disaccharides are big molecules. They will not be really transported into the blood. So glucose ang ending para ma-transport siya sa blood, ma-absorb siya. So this how the alpha-glucosidase inhibitors help the person with diabetes mellitus. So bisag mukaon sila carbohydrate-rich foods, the digestion will be delayed and so does the absorption or inhibited, pwede din inhibited. So what are the examples of our alpha-glucosidase inhibitors? The miglytol and the acarbose. So brand name of this one in the market, the most common is the Glucobide. Glucobide daw na pagbasa, dili daw Glucobay. Pero arte-arte man ta, so sige, Glucobay. That's the acarbose and the miglytol. What's their difference? Miglytol is 6 times more potent in inhibiting the sucrase though than the acarbose. Sucrase is another enzyme specific for sucrose. So ang atong table sugar, that will also be digested in the body by the sucrase to, let's say nasa sucrose, glucose o fructose, right? So para ihiwalay na to si glucose and si fructose. So that's a disaccharide. Mao na ang trabaho lang ni miglytol. Kung i-compare nato siya with the acarbose. What will be the adverse effects now if mag-take ta og alpha-glucosidase inhibitor? We have the flatulence because you will be inhibiting the digestion. So, syempre, the problem will be on the stomach. You will really have problems with the digestion like flatulence, diarrhea, and abdominal pain. Meaning, indigestion. Unang na ang problem na to. Kag inhibit man nato ang digestion, so we will have indigestion exhibited by flatulence, diarrhea, abdominal pain, or in some cases, the patient will also experience hypoglycemia. Hypoglycemia na siya kaya wala naman na transport ang glucose into the blood. Okay? questions about this one? Our what do you call this? Alpha glucosidase inhibitors. May pangutana? Let's move on sa other agents natin. We have the Pramlintide. Pramlintide, which is an injectable drug. This is not really an oral hypoglycemic agent. This is an amylin analog, injectable. And what's the mechanism of action? It's more on the modulation of the postprandial glucose level. So, binibigay siya preprandial before mukaon. But pwede siya for both type 1 and type 2 diabetes. Again, pwede siya sa type 1, pwede siya sa type 2. Kasi it's more on the modulation of the glucose levels after eating. So it doesn't matter whether there is an absence of insulin or problem with the resistance. Kasi it's more on the food na kinakain, the digestion for that also, that's the work of amylin also in the body. So since this is an analog of amylin, parehas silang trabaho. Ang pag-produce or paghatag of glucose in the blood, transportation of glucose in the blood. So adverse effects of this pramlintide is hypoglycemia, and then common na yung nausea, vomiting, and anorexia. Now we have the Xenotype, which is a synthetic analog of glucagon-like polypeptide 1 or the GLP-1, which is the first incretin used in therapy. And just like the amylin, this one is also an injectable which increased insulin secretion. But you still have there the anorexia, weight loss, and pancreatitis. By the way, ganito kasi ang mangyari. If we eat, example, nagkaon ta, if we eat plus, prandial ang tawag na to, ha? Our body syempre will react. Due to stimulus like mag-increase ang glucose kay nikaon ta, there will be release of insulin. Okay? Again, there will be release of insulin. But aside from insulin, there will also be release of glucagon. Nikaon ka, nidaghan imuhang glucose, musamot pa jud nagkadaghan kay na-release si glucagon, and that will trigger the liver to produce more glucose. So, na siya ang problema pag bukaon kadaghan kayo ma-release. Now, aside from that, if you eat, aside from these two, GLP-1 will also be released. Itong si GLP-1, ang trabaho niyan is to inhibit release of glucagon. So now, since GLP-1 analog man ito, this will help in the anong tawag dyan? Pag-maintain ng glucose level also. And since i-inhibit niya si glucagon, that will result to the shift in the increase of the release of insulin. Kaya ito yung kanyang MOA, increased insulin secretion by inhibiting glucagon, inhibit ang more glucose produced by the liver. Pero again, this one is injectable subcutaneously. We have anorexia and weight loss here, but our problem is the pancreatitis. Naglibog ng pancreas, inhibit nato si glucagon, padaghanon nato si insulin, which is supposedly sabayan sila i-release kapag kumain tayo. And then we have the sitagliptin, mga gliptins natin. Marami ito sila sa market, not just with the sitagliptin, but take note that they are DPP4 inhibitors. Dipeptidyl peptidase 4. That's the meaning of DPP4. Dipeptidyl peptidase 4 inhibitor. The DPP4 is the enzyme that degrades incretin and other GLP-1 like molecules. So si incretin kasi yan si GLP, parehas sila ng trabaho. Sinabi ko kanina GLP-1 and then let's add the incretin. What will they do? They will inhibit the glucagon release para walang more glucose na ma-produce by the liver. But our problem is in the body, meron pa tayong isang kontrabida dyan, and that's the DPP4 or the dipeptidyl peptidase enzyme. Sa trabahoan ni, inhibit this the GLP-1 and the incretin. So kung wala ni, wala mag-inhibit sa glucagon release, musamot og kadaghan ang glucose. So we have another drug now that will inhibit this DPP4 para daghan tag GLP-1 or the incretin. That's the gliptins. Marami tayo again gliptins in the market. The sitagliptin for example. So this will also decrease postprandial glucose excursions. Yan naman ang trabaho ni GLP and ni incretin. What's our problem with the gliptins? We have nasopharyngitis, inflammation of the nasal tract and the pharynges, URTI, upper respiratory tract infection, headache, and severe allergic reactions. Those are the adverse effects. So that's the end of the chapter 28. Any question, class? So far, we still have time, so we'll just utilize it for the question and answer portion. Yun lang yung mga drugs natin for the diabetes mellitus. Na may gusto ipangutana? I-clarify? Actually, my study for the PhD is about metformin being used in COVID-19 patients with diabetes mellitus kasi there are studies na nakita nila that it can reduce mortality rate reduction. May oral hypoglycemic na hindi talaga pwede isabay for insulin therapy. Let's look at the drug-to-drug interactions for that. Nag-download na mo Medscape Plus. Nabagyan nga mo mag-download na mo Medscape. Kasi since sa kadaghan, cannot really memorize this one. Kasi so far sa akong nabasa, wala pa ko yung nakita na oral hypoglycemic agent that should not be given concomitantly with insulin. Pero let's check para mas accurate. By the way, aside from sitagliptin, we have the saxagliptin, and sagliptin. They are called DPP4 inhibitors. Mostly man good ang drug interaction between insulin and the oral hypoglycemic agents, hypoglycemia lang. So mo lang na ito ang problem. So mo na nga wala kay ko nakitaan nga drug interactions between insulin and the oral hypoglycemic agent. So far, wala dito nakita. Let us check more. We can pressing insulin mo. Di ay. Wait lang ha. Kaya wala di ko internet. Kaya lang si ulit stove. Ulat mo lo. Full storage. No, full storage naman. Actually, the Medscape is very useful. If I'm not really sure about the drug interaction, I just check it here. Kasi mag-signal magudin siya kung na ay drug interaction. Kasi naka-download na og Medscape. Lihok akong cellphone. Ako mag-home cellphone nga na ay Medscape kani. Ako ang old nga cellphone. My problem is since old siya. Sige siya glag. I don't want to get the Medscape sa ako ang isa ka phone. Kaya ma-full storage na. Free? Yeah, free lang. Now, daw, Rosel, kindly check the drug interaction between insulin and the other oral hypoglycemic agents. But the Medscape is the most accessible sa ako Kapuyan ko magbasa og mga articles, mga journals. So sa Medscape, butang naman nila tanan. Free lang, Sarah. You just download it. Wala nang lihok ko sa cellphone. Pero so far ha, again, I did not see sa books na ako nabasa na may interaction sa insulin with the oral hypoglycemic drugs. So, ano siya? Pero may sila actually ginagamit in combination. So far, insulin and metformin, insulin and sulfonylureas, ginagamit sila. Wala na nilihok ako cellphone class. Tubagon pa ka Isabel pag malihok na siya. Pero ang akong tubag so far, wala pa ko'y nakita na kanang dili gyud pwede isabay si insulin and another oral hypoglycemic agents. Bugay naman kung wala na on ang iyahang wifi. So, pag on na ko, wala na. Ihang na siya, kaya daghan na kayo ang messages sa messenger. Anything else? Or kung nakay time ay subal pag-download og Medscape, kunya i-check din ha kung na ba kayo makita. Kay so far ako wala. Except for hypoglycemia though. O na ang imuhang makita nga interactions din ha. Ang ibutangan na niya hypoglycemia. Kaya labi na pag masobraan na. Wala na kay storage. Lisudan, wala kay storage. Or if if you have someone in the family na naga-polypharmacy, you can always check the interaction kung tama ra ba isabay-sabay na iyahang mga drugs din ha. Tanawan ninyo sa Medscape. Tapos if you are not really sure, dili kayo mo kasabot sa inyong gibasa, you ask me. Send ako Okay, let's see. Unsa ginaingon sa interaction. Anything else before ta mag-end? Still have 2 minutes.